Okay. Good morning, good afternoon, and good evening, everyone. Thank you very much for joining us for this webinar titled Demystifying Scope and Scale, Making Faith-Based Organizations Count in Health System Planning. Yes, we are watching that there are a lot of people joining now. So let's wait for a couple of more minutes for everyone to join. Is it okay for everyone? So wait for a couple of more minutes. Hope everyone is hearing me.
We hear you, Edwin. Probably can go.
Thank you so much. That's very important, actually. Yeah, just wait for a couple of moments. Exactly by 6:35. Oh, sorry, 9:05. We can start. And those people who have joined news, thank you so much for joining us, and we'll get started in a minute. Okay. Thank you once again for joining us, and we're going to start the meeting. And it's really our pleasure to welcome you all to the webinar on demystifying scope and scale, making faith-based organization count in health system planning. Thank you very much once again for joining us today from different parts of the world. We are pleased to mention that there is French interpretation for this webinar, and you need to click at the bottom of the screen for the French translation. When making this selection, you can also choose to mute the original sound of the speaker. And welcome and thank you once again, the speakers and audience, for joining us. My name is Edwin Sam, and I'll be moderating the webinar and the discussion today. And if you are new to CCIH, Christian Connections for International Health, we are an international network of approximately 100 Christian organizations, 15 affiliated partners, and a few hundred individual members, all working in over 90 countries across the world. Our mission is to promote health and wellness from a Christian perspective and provide opportunities for capacity building, networking, fellowship, and advocacy. And Bob is entering the bios of the speakers in the SAT slide, and which will allow us to give more time for the speaker and for further discussion. But I will give a very short introduction of the speakers now. And the first distinguished speaker is Amanda Vigneaud, currently working as a Deputy Director of USAID'S Center for Faith-Based and Neighborhood Partnerships. And thank you, Amanda, for joining us. And Barbara Campbell is our next speaker. She's the Executive Director of Dalton Foundation, primarily working in Haiti. And the third speaker is Doug Fountain, serving as Executive Director of Christian Connections for International Health. We all know, and several reports have also highlighted that faith-based organizations play a substantial role in health service provision, especially in developing countries. And it is up to 70% of the health services in some countries. At the same time, studies have noted the lack of robust data in faith-based health services and the need for methodologically sound estimates. Therefore, data on FBOs need to be appropriately collected, organized, analyzed, and made accessible to inform healthcare programs and policies. This webinar and our discussion today would focus on understanding the scale and scope of faith-based organization health services and how to ensure that the faith-based health community is counted and included as part of the health system strengthening across the world. To begin with, we are going to get the donor's perspective from our guest, Amanda, Deputy Director, USAID. Amanda, welcome once again, and over to you.
Thank you so much, Edwin. Well, good morning, good afternoon, good evening, everyone. My name is Amanda Vigneaud, and I serve as the Deputy Director of the Center for Faith-Based and Neighborhood Partnerships at USAID. And I first just want to thank Doug Fountain and Christian Connections for International Health for inviting me to participate in today's webinar. It's always a pleasure to join you, and special thanks to Edwin for facilitating today's panel. USAID and CCIH have a long history of collaboration, and I'm honored to be part of the conversation today to carry that tradition forward. Now, my guess is that most of us in this virtual space today are familiar with the contributions that communities of faith bring to development broadly and to global health specifically around the world. And today's conversation is meant in part to ensure that these contributions are counted and included in health systems strengthening strategies. For those that don't know me, prior to joining the Center for Faith-Based and Neighborhood Partnerships back in 2019, I spent 5 years working in the agency's geospatial and mapping unit. And that incredible team is called the Geo Center, and it's USAID's internal team of geographers and data analysts that provide direct programmatic support to USAID staff around the world in an effort to promote a geographic approach to development. And during those 5 years of working with the agency geographer and the team, I really came to appreciate and understand the role that geography and geographic information plays in our development programming. It not only helps us understand where we and our partners are working relative to the areas of greatest need in the places that we work, but it helps us make strategic decisions about how to invest taxpayer dollars in ways that maximize development and humanitarian outcomes. And I've really tried to bring this mindset with me as I joined the faith-based office, which has a little bit of a different mandate. We work to build bridges between USAID and faith-based and community groups. We have a mandate from President Biden to do that, and we actually engage with a number of community organizations around the world, from local religious communities and organizations to diaspora groups, volunteer networks, and foundations, all as a part of the US government's goal to advance shared diplomatic, international development, and humanitarian goals worldwide. And we also dedicate a portion of our time to strengthening the agency's capacity to collaborate with these communities through agency training, research, and policy guidance. And so the faith-based office has a 20-year legacy within the agency. And across these 2 decades, we have made a conscious and concerted effort to bolster our commitment to partnership. And we do this because local religious communities and FBOs are first and foremost our partners in development. We work in shared spaces, often with the same goals in mind, and it's simply to our benefit to learn how to collaborate with one another. The second reason that we promote partnership is because the data demonstrates that working together quite often helps improve our outcomes. FBOs and religious communities offer positive contributions in the development sphere, most notably in global health, by building trust and access, reach, and history that's distinct to other development partners. And those contributions help us expand the scope and the effectiveness of our programming and efforts on the ground. And like I said, this is particularly true in health. From research investments that USAID has made over the last 3 to 5 years in particular, it is crystal clear. Faith communities have long been at the front lines providing essential medical care and humanitarian assistance to those in need. And faith-based organizations are a critical part of the tapestry of healthcare systems and services around the world. And we know this came into sharp focus during the COVID-19 pandemic, but it's in no way limited to that time period. FBOs are meeting critical health needs every day in every corner of the world. And that is why it's so important for faith-based health assets to know and capture and share their geographic data when and where appropriate with donors like USAID and others that are making investments in global health programming. Because this information is critical not only in responding to crises and humanitarian disasters, but it's absolutely pivotal to the long-term development and capacity building of our global health systems. And so I want to take just a couple of minutes to share about some of the exciting work that we're doing inside USAID to advance this work inside the agency and provide some greater context on how we are approaching engagement with local actors to give you a sense of where you can lean in to help us shape a more effective and prosperous future. On the GeoCenter side, we have been working across multiple sectors and missions with a variety of implementing partners to turn data into decisions for over a decade. And just to give an example of this, the GeoCenter most recently helped to improve the Rwanda mission's ability to coordinate among partners within the global health and nutrition sectors by analyzing and working with implementing projects across the country to target the right populations in need. And I found it really interesting. I got to see this project firsthand, that by analyzing and mapping household survey data, they uncovered demographic differences in local religious populations that actually changed the mission strategy to promote reproductive health and more effectively address the needs of mothers and children in Rwandan communities. Those are the changes that we can see in outcomes and in strategy when we collect and analyze and share geographic data. And like in Rwanda, more than ever, we can share and use this information to understand local communities and plan our programs based on data that reflects the realities on the ground. And so to help us advance these kinds of efforts, USAID is currently in the final stages of designing its first ever geospatial strategy. In addition to acknowledging the Geospatial Data Act of 2018, this strategy establishes an agency-wide framework for adopting geospatial data and tools and strengthening capacity and partnering to advance geospatial solutions for international development. And it aims to mainstream that geographic approach to advance development outcomes in the next 5 years. And I'm really excited to announce that that strategy is actually out for public comment right now on USAID.gov. I'll drop the link in just a minute in the chat so you can see. It's available until October 26th. And we just encourage you to please read the geospatial strategy and comment on it, highlight the role and the importance of mapping faith-based assets in particular, and specifically in the global health sphere, because comments like that really help us improve our policies, make them stronger and more inclusive of local religious communities. I'll note 2 other policies before I close out. Many of you on the line know that USAID's local capacity strengthening policy actually launched this morning at 8 a.m. Eastern Standard Time. We're all very excited about, and I'll also share that link to the final policy in the chat for you all to take a look at. And then finally, and this is a policy that's near and dear to my heart because I've been helping to shepherd it for the last 2 years, USAID is preparing to introduce the first of its kind religious engagement policy, which is called Building Bridges in Development, a policy on engaging faith-based and community actors. The policy has 2 parts. It includes both a set of principles to guide the agency's strategic religious engagement efforts, and it establishes a framework for putting that engagement into practice. And so I just wanted to share some of those policies with you this morning because really combining faith-based communities, global health assets local community efforts in geospatial mapping and information, these are the ways that we are embedding these priorities into how the agency operates. And they are all part of how we're working to advance USAID's localization agenda. From our perspective, localization encompasses the processes and the actions that we are taking as a donor agency to ensure our work puts local actors in the lead, strengthens local systems, and is responsive to local communities. And for the localization agenda to be realized, these policies and conversations like the one today really must continue. So thank you so much for your time. I look forward to continuing to collaborate with CCIH and many of you on the call. I thank you for your work and leadership in the field and look forward to the discussion after. Thanks so much.
Thank you very much, Amanda. It was so good and it was a wonderful and insightful presentation. Thank you so much for that. And I'm sure that there will be a lot of questions from the audience, and we'll keep it all in the last part of the webinar. Next, we're going to hear from my co-chair of the Data and Mapping Working Group, Barbara Campbell from Dalton Foundation. Barbara, over to you.
Thank you,
Barbara. Yeah.
Good morning, good afternoon, and good evening, everyone. And thank you, Amanda, for that great presentation and launching of this time together this morning. I am Executive Director of the Dalton Foundation, and mapping is really important for everything we do, whether it comes to funding or whether it comes to trying to expand, expand our work and achieve more funding. We really like to understand what's already going on and how to best augment it, not to duplicate, and to highlight great efforts. So this is a topic near and dear to my heart. And as Edwin said, I do co-host the Data and Mapping Working Group for CCIH, and that's been a privilege. Today, I'm going to talk to you about the Christian Health Asset Mapping Consortium. I'm going to share a little bit about what it is, how it got started, some of the objectives, the work to date, and then how you can get involved as well. And also, I hope you'll hear the why behind it as well. Kathy, you want to go to the next slide, please? All right. As Amanda said, it's really important and it's a priority for faith-based organizations to be counted, but that's one of those things that can be easier said than done, right? And so what does it look like to tackle the challenge of aggregating data and reporting it out? And I thank Doug for his great leadership in this vision of creating, CCIH is the secretariat for this, leading the efforts to create this mapping consortium. We know there's challenges where facilities can be undercounted. There's, on my next slide, I'll show some of the reasons for that and the complexity that's involved. There's data that exists, but it can be of inconsistent quality. It can be of inconsistent, actual matter that creates challenges. And the goal of this is to create a strategy that helps to provide information about the scope and scale and to allow people like members of CCH know that this data exists, be able to use it in your work to help you, and also to make sure that your work is being counted. So next slide, Kathy. I love this graphic that the CCIH team put together. It's very pretty way of demonstrating a very complex situation. When you think about the Christian healthcare delivery landscape, it's multifaceted. It's not just as simple as this facility is here. It's about what the organizations are doing, how they're supported. Some organizations are directly providing services, some are providing support, the different locations involved. So it's a very complex project that this consortium is looking to help quantify and provide some practical information for. Kathy, you want to go on to the next slide, please? All right, so a little bit about kind of the who of this mapping consortium. It was launched in January of this year. Perhaps many of you were at that meeting where we shared the launch. We're really thankful for all the organizations that have stepped up and said, we want to be a part of this. These are all organizations I will be very humble. Our organization is the smallest with the least contribution. Everybody else is absolutely incredible, saying, hey, we have access to some data that we are willing to share what information on that data we have to be a part of this community so that we can try to start sharing this and making this data practical and useful for everyone to use. So a big thanks to every organization. I know many of you are on the call today for all that you've done in these efforts. Go on to the next slide. This is one of the ones I really want to focus on, is what are the objectives of the consortium? What does the consortium seek to do? And what is the consortium not going to do? I think number one there, the registry of data is really important. The goal is to create, like it says there, a database of databases. So this is where you can come to learn what data sets do exist about healthcare facilities or healthcare support services. So this is a really important place to find that. Then I loved what Amanda said about the purpose of collecting, analyzing, and sharing data. Every single one of those things is important. If you collect it, but you don't analyze it, if you analyze it, but don't share it, it's not practical to everybody. And I think, and I know the consortium is committed to all three of those things. So aggregating those databases together, being able to analyze the data to extract relevant and important information that's both vital for funders and vital for members of CCIH will be a key component. And then thinking through how to improve the data. What can be done to help us gather better data to help organizations like USAID and others understand the scope and scale of work that the faith-based community is doing. A question that's commonly asked, and one thing to point out that we definitely are not doing, is gathering a specific huge data warehouse with locations of every single healthcare facility and what they're doing. It's more about connecting you to the database that lists everywhere you can find that data so you know where that is. And I can clarify that with questions if there's questions on that. The progress to date, which again, I thank Doug and team for leading. There is a registry available. So the data of databases, you can get that information. And then we have put out a data brief as well. And this is, I will talk a little bit more about that on the next slide, but that is a tangible thing you can find on the CCIH website that you can use if you're doing work in Africa. It could help you with grant writing. It could help you with the work you're doing in a specific country. I highly encourage everybody to look that up and utilize it. And another great outcome so far of this consortium is that we're represented on the WHO's Global Health Facility Data Working Group, which again gets the faith-based community that global audience, that global stage in order to highlight our work. So I think that's really important. And on to the next slide. This is a little summary of that data brief that I mentioned. This is where we've taken data and this is where it's been aggregated, it's been analyzed, and there's some things that have been pulled out of it that can be shared, that can be useful. There's a little summary highlights of the data there. There is a lot more data though on the CCIH website, which I will share the link to you. Looks like Carolyn's sharing that link in the chat right now. Thank you, Caroline. But there's a lot of great information, not only on the consortium that I'm sharing with you, but also on this data brief and ways you can apply it to your work. And there are other countries and other data that's being aggregated and analyzed that we hope to share with everybody in the very near future. Can go on to the next slide. And the last thing I just want to share is just about getting involved. I think that CCIH does a wonderful job of including us, wanting to share information with us. We encourage everyone to learn more about this. If you have resources to share, we have a Google group where you can share it. You can also directly reach out to be a part of this. We want to make sure that everyone is counted. The work they're doing absolutely vitally matters. And we also want you to have this information so you can use it to support the work you're doing. And that's all I had for today. I look forward to the questions later. And thank you again for having me here and for everybody participating today.
Oh, wow. Thank you very much for this wonderful and very comprehensive update on the consortium, Barbara. It was very good. And our final presenter is Doug Fountain, the Executive Director of CCIH. Doug, welcome and over to you.
Thanks, Edwin. Thanks, everybody, and really appreciate everybody being here for this talk today. We are grateful to be part of this global community that is working hard and rolling up their sleeves to make sure that we have access to terrific data and information to share. I'm going to actually dive in a little bit into CCIH as a case study for that, because one, we are a part of the consortium. We do have member data, but how we're thinking about the data may help also explain or help contribute to understanding about the faith-based landscape. So first up, as you know, CCIH is a global network. We are committed to capacity strengthening for local organizations and engaging faith leaders as partners in that work. And we do seek good data on the nature, scope, and scale of our members to assist us in our advocacy efforts, to contribute to research, and to build effective partnerships. Obviously, when we look at the CCIH data, we know that these are members, they're self-selected into CCIH, and so this is not globally representative, but it does create a good case study of how the faith-based landscape really does work. So next slide. Why is this important for us? There are at least 5 different reasons that we think that this is important for CCIH. One, we want to identify complementarity in core functions so that we can learn. When somebody's doing something similar to somebody else, we can foster learning that will help one benefit the other. We can support scaling of proven interventions in order to broaden the impact of what any one of us is doing. It can help reveal gaps in services so that we can overcome them. It'll help us coordinate resource flows or even find new resources, as we've helped to do in many instances. And finally, it's going to help us overcome silos by helping us understand how the different partners work, where they work, what they do. Is going to help expand our knowledge about how all of the pieces and parts work together. So for example, I really do understand that our members may specialize in 1 or 2 or 3 things. And so they might say, I'm a missions mobilizer, or I improve the supply of drugs and supplies, or I train community health workers. Each of those is a good thing, but by itself, it's not the whole picture. It's not the whole solution to the global health challenges that we face. So how can we understand and put the pieces together? So that's why we're taking a broad look at that. And Kathy, go on to the next slide. So again, we'll take a step back and think about who our members are and where they work. Updated data, thanks Edwin for the lead off. We actually just recounted and right now we have our members are working in 108 countries. Just about, close to half of them work in only a single country. They're registered and work in a single country. And in fact, over half of our members, over half, are headquartered in low and middle income countries. So it's important to understand a little bit of who these actors are. Many of them are local organizations. We also have some very large organizations in our membership that work in 60 to 80 countries around the world. So that's just a little glimpse into where they work. But now let's talk a little bit about how they work. And so I'll go back to, on the next slide, please. I'll go back to something that Barbara shared, which is this landscape slide. And really to unpack that, there are the health facilities, then on the bottom right, Christian community health programs, and then on the left, congregational or church-run health programs. And then linking all of those are drug and medical supply organizations, health worker training institutions, universities and colleges, International support partners, that might be international NGOs, and then of course health networks, such as the Christian health associations. The challenge is, this is a nice picture. It is a pretty picture of what the landscape looks like, but it's not drawn to scale. So what is the relative size and contribution of each of these? What do we really know about that? And that's the next slide, if you would go to that. Looking at CCIH members, we've been compiling this information that we know 63% support direct services, 38% provide direct services, and then 19% actually do some of both. That's really important because when people talk to us, they assume that our members are mostly made up of direct service providers, but they're not. They're actually over, that 63% are supporting direct services. Now, what does support mean? The most common things that they do are technical training, maybe advocacy at national or global levels, leadership support through perhaps the networks or health associations, providing medical products, either through donation or procurement, volunteers, and volunteers may be missionaries, or it may be other types of volunteers who are deployed to go work someplace. And then finally, funding and access to funding. That's all on the support side, and that's part of what our members are doing. On the service provision side, the most common things they do, not surprisingly, they split. The ones that are doing services, about half of them do community health and wraparound services, and about half are doing health facilities. So it's really important to understand the diversity here. Again, if you think that the Christian health landscape is Christian-owned hospitals, or it's only Christian-run community health programs, both of those are true, but it's not an either or, it's a both and. So that's a little lens into what they do. Now I'm going to go to the next slide. And this one is really complicated. And we tried to keep this, we thought about adding arrows and adding a lot of things to unpack how these layers and functions all work. But bear with me for a minute as we unpack this. Down at the bottom, we depict health workers, health facilities, and community health programs. Now the question is, how do all of the partners in this immense global health landscape all contribute or support those functions that are happening, those activities among health workers, health facilities, and community health? So at the top, of course, funders and then supporters. Supporters might be champions for causes. It might be churches that own or mobilize services. That at the top level. That could be, then the next layer might be volunteer medical donation or organizations, advocacy organizations is another layer, leadership support, and then training for workers. This is just trying to pick out a few of these to show, and you see how they line up. Funders and supporters might support or benefit health facilities and community health programs, but they don't do very much often with health facility workers or direct health workers. Volunteers and medical donation programs might work with health workers and health facilities, but they don't do much with community health programs. Advocacy would be for health facilities and community health programs. Leadership support heavily favors health facilities. And then you see two different types of training, one for doctors and nurses and people who provide direct services. The other is training for those community health workers. Now, this is not the entirety of all things that are happening in the global health landscape, but it's just pointing out the layers. So a funder might support volunteers and leadership support for some health facilities. Or there might be advocacy for better leadership and training in community health. So you can just imagine that there's arrows going down and linking down through each of these. So it's a very complex landscape. What we're trying to do is to really start to separate out what the layers are so that we understand who and what each of these layers represent. I'm going to go to the next slide, and maybe this will also help explain this picture. So now when we pick out just two, the health facilities on the left and community health on the right, what you see is how the partners work in support of health facilities or partners work in support of community health. There are going to be areas where they cover, but there's going to be areas where there are gaps. So health facilities are covered by some health associations and networks, but many health facilities are not covered by any of those. They don't have any benefit that's assuring training, access to resources, access to support. So they're on their own. Similarly, in community health programs, many of them are supported by NGOs or funders, but many of them operate on their own, perhaps in conjunction with a local health center, perhaps as an outreach from a local church, but they may not be tied to any other groups or benefit from any other type of network. So we see these gaps. So now at CCIH, you can appreciate that we have these different layers of support for local health action. But then when we also look at in each of those, we see gaps in who's receiving that type of support. So with that, we can go back to the original purposes and think about partnerships, learning, cross-pollination across these different efforts so that we can help fill in some of those gaps. And last slide, please. I'll just go back to the one issue that I think is pivotal for us. And it's the question that I really want to challenge us with. How can we take any best practice to scale if we do not understand the systems and the context in which that must take place? How can we take anything to scale if we don't understand the systems and context in which that takes place? I think we at CCIH would join the chorus that is concerned that we continue replicating pilot programs in health without investing in the systems to take proven necessary interventions to scale to truly ensure timely access to quality health services, be that in communities or facilities for those most in need. Who's responsible for that? How do we bring partners toward that vision? Frankly, that's our journey at CCIH. So I hope that unpacks a little bit of how we're thinking about mapping and data and what we're trying to accomplish here. Thanks so much. And Edwin, back over to you.
Yeah, thank you very much, Doug, actually. And thank you so much for correcting my error also. And it is not 90, it is more than that. Thank you so much for that. And I'd like to extend my sincere thanks to all the speakers for sticking to the time, actually. So we have a lot of time for discussion, which is very, very important. And can we now go to the questions, actually? There are some questions popping up from the chat. And the first question I would like to read, it is from David Basto. And the question is to all three of you. Are you looking at data about social drivers of health? For example, the impact of local faith communities on the stigma associated with HIV and AIDS. Should I read it again? Are you looking at data about social drivers of health? For example, the impact of local faith communities on the stigma associated with HIV and AIDS. Any three of you can. In the meantime, the audience can put their questions in the chat box. Yeah. Who?
I can answer that from the perspective of our work personally. I'm taking off my mapping consortium hat for the moment, because to my knowledge, to answer it from the mapping consortium perspective, and Doug, you can certainly correct me, I don't think we're specifically gathering data on that topic. It would be more about finding a database that does collect that data and making that awareness. But I don't know if any of the data actually has that information in it. Maybe you do, Doug. I know in our work, that the mapping work we do in the context of Haiti, yes, we do. And we have a database set up for the country that we use to display that. I think it's very important. And I just want to comment on how Doug ended what he shared, because it was really excellent. And I think that's so important when you talk about scaling and you use the phrase like responsibility for scaling. I think, starting a pilot project and seeing it be successful can kind of be the easy part, even as hard as I know that is. but then being able to know the partners, know the context for how to scale it successfully can be really challenging. And so understanding networks, understanding what's going on where and how it's being done is really vital to scaling. And we know that scaling of great ideas is going to be what really impacts healthcare. So I can't emphasize that scaling enough and the importance of it. So that's my answer in a roundabout way.
Barbara, thank you so much for that. And there is another question from Catherine Marshall.
And when I might,
Please,
that's
please,
all right.
please,
No,
please,
it's okay.
please.
I might just weigh in on one thing, and I appreciate the question. I think in the question, it reveals two things that are hope fors in our work. Barbara's right. We're not collecting, but if somebody's got the data, we want to know about it. Okay. So step one is who's investing in those stigma programs and what data do they have? PEPFAR has got tremendous amounts of information and data about what's happening in the faith sector. So it's a natural next step for us to integrate there and at least be able to know what type of stigma programs are taking place. The second part of that, though, that I'm thinking about, remember that landscape and the three big circles. The bottom left of those circles was the church-run health programs. And I see a lot of activity within among faith leaders and in church-run programs to try to address stigma, to deal with gender-based violence, to deal with all sorts of issues, frankly, that they prioritize. I don't know anybody who's capturing information about that. And that's a natural opportunity for somebody. I see one of our mapping group members, one of my board members, and somebody from World Council of Churches might want to weigh in on that at some point too. So yeah, thanks for that.
Okay. So the WCC member won't
maybe later.
Come in?
We won't put
Okay.
on the spot just yet.
Yeah, thank you so much. And there's very interesting question from Catherine Marshall. As you look at the challenges of health system strengthening, including in fragile states, how do you see this knowledge contributing in meaningful ways? I'm repeating the question. As you look at the challenges of health system strengthening, including in fragile states, how do you see this knowledge contributing in meaningful ways? Any one of you? It's common. All three of you can answer this.
Yeah, I can just give some thoughts. It might be an unsatisfactory answer, but it's definitely a priority of USAID's right now. There's a few areas, particularly in our post-pandemic world, that we're focused on, and one is strengthening health workers and primary health care in the world as we're learning to live with COVID, and reclaiming the ground on our key global health strategic goals, which falls in a few areas: preventing child and maternal deaths, combating infectious diseases, and controlling the HIV/AIDS epidemic are three of the critical areas where we're looking to do this. And it really requires addressing the core sources of fragility in low and middle income countries to do that. There's just a lack right now of a strong health workforce in many of the places where we have a presence as USAID, and making sure that we're consistently investing in paying and training and supporting and coordinating those local healthcare workers is a critical way that we're trying to address strengthening primary healthcare systems, which we know is really the heart of resilient health systems. That includes health workers and their livelihoods. One of the ways we're doing this is through an investment in the President's Health Worker Initiative. And if you're not familiar with that, it's one of the ways that we're seeking to establish a stronger workforce that can really be flexible and adapt to the shifting needs, to focus on saving lives that need it most. And that includes in fragile communities. Our Global Health Bureau has been really at the forefront of this for years, but with little direct investment until now. And so that's one of the ways that we're really seeking to address those challenges in healthcare system strengthening, inclusive of fragile states. And then maybe later I might talk more to the global health security piece, because that's another critical area, particularly as it intersects with fragile states. But I'll leave it at that for now.
I might add to that. There's fragile contexts, and we often think of fragile contexts as entire countries, but sometimes the fragile contexts are regions within a country where there's instability, and sometimes when we talk about health systems, we gloss over those things and just refer to the country. But the question is, in a given country where there's difficulty, I'll pick Nigeria as an example. What you experience in one part of Nigeria is very different than in another part of Nigeria. So how do you plan around that? And that fragility, whether it comes from conflict, climate, other factors, you may have displacements and surges in health services. Surges in demand for health services. A local health system needs to figure out how to cope up with that. So I think we will contribute to that. But Barbara, I wonder if I could deflect also to you for a second, because when I think of fragile contexts and data, there's nothing like what you've got in Haiti in terms of really good data.
Yeah, I was going to chime in and add a little about that. Yeah, we've been collecting data on every single healthcare facility in Haiti for the past like 5 years now, since I started this role here. And we utilize the data in quite a few ways. And I will say, in the context of, yeah, Haiti's the fragilest of fragilist, especially right now, how we utilize that data in many ways. So one, we have the ability to connect with organizations and leaders just like that. We've taken the data, and even in the good times, we set up WhatsApp groups regionally. We have regional meetings to connect the leaders, and we have formed a little bit of a community. And what that allows is, when things get rough, we're able to communicate and share resources really, really quickly. We're also able to work with organizations and let them know where they can have the most impact. A specific example, last year, the earthquake in 2021 happened in the southern part of Haiti. And we had an organization contact us wanting to come in and help. They had the capacity and ability to come in and set up a field hospital and go forward with that, but they don't work there day in and day out. Can you help us connect us to the right partners? Can you help us find the most strategic place to go? And can you help us stay safe throughout the process? And so we were able to do that within hours of the earthquake happening, because we have all that data and ability to connect very quickly. And I could go on for a long time on what we're doing right now with the state that Haiti is in right now and the healthcare workers. We've used a lot of that relationships and information a lot for advocacy, to highlight what's happening with the healthcare community in Haiti and the healthcare system in Haiti, which is deteriorating extremely rapidly due to the realities. And then also now with the emergence of cholera, we're creating regional different groups using the data to understand what cholera treatment and prevention resources are already on the ground in Haiti, because right now bringing things in is not, our usual solutions are not going to work. And so we have to really rely on what's already there. So being able to aggregate that quickly and share it so that facilities have everything they need to treat and prevent. So it's a little bit of how we use our data.
Thank you, Barbara.
Yeah.
Thank you very much, Barbara. And yeah, we're seeing Moy's hands up. Thanks, Moy, for coming in, and our WCC friend is here. And Moy, it's over to you. It's over to you. Moy, you can unmute. And
Moy may
speak.
not be able to unmute himself.
Okay.
Yeah.
Oh, sorry.
Okay, thank you for giving me a voice. I just wanted to add, in terms of data, and this I think is usually my point of concern, that the target audience of our data mapping and all that is both sides, the development agencies, the governments, the ministries of health. On the other side, we also have the audience of the churches, the church leaders. So when Doug, you mentioned about data analysis, so after the data, the raw data, we process it into useful information. And then we I think, are the go-betweeners we should be able to be bilingual, to talk the language of the faith communities, the faith leaders, and the language of the ministries of health. So when we have one data set, I can imagine two kinds of reports. One report targeting faith leaders in the language they can understand, in the language that speaks to them, speaks to their interests, speaks to their challenges, speaks to their sensitivities. And also another language, another report which actually speaks to the language of the ministries of health, the language that resonates with them. And we have to be bilingual. Last week, I attended a meeting in Thailand, a consultation organized by the Christian Conference of Asia. There were over 20 participants from many countries in Asia. Very interesting was that in the group, we had medical doctors, we had hospital chaplains, we had pastors, church ministers, and university academic kind of theologians in one room. I think that's a better way to be able to hear each other, to see when you're looking at health work in Asia, what is it that resonates with churches, church leaders, and what is it that resonates with hospital administrators, medical doctors? And thinking in that way, we will be able to have much more meaningful utility of the data that we generate, and also to see how that data would be able to help those different audiences. So I think it's when we are designing these kinds of data, we should already cross-check before we go on a data collection expedition. What kind of data will the faith leaders that are the owners and have a stake in this kind of service delivery, what kind of information, what gaps do they have? What knowledge gaps would we find ourselves useful to bridge those gaps? And then we also look on the other side, and then we can now embark on a data collection expedition, knowing that when we come back, we'll come back with something which the respective audiences are going to find valuable. So data collection, which is not appreciated by those audiences, will just be an exercise, but that may not necessarily be very useful. So the utility is not determined after the data has been collected. The usefulness is determined before the data has been collected. And so understanding those existing data gaps before the data collection exercise, and then when the data is out, we now find ways of packaging it in the language that the respective audiences are going to understand and use, find useful within their respective constituencies. Thank you.
Oh, thank you so much. Thank you very much, Moy. And we have a couple of more hands up actually. Bruce Compton, can somebody mute him and he can talk about it? Yeah, you can.
Good morning. I guess it's my day to follow Moy. I was on a call with him earlier about what I'm going to actually talk about, which is we're part of, and Doug and CCIH is also part, Catherine Marshall's part of the WHO Communities of Practice, and they've given us, for faith-based leaders, and they've given us access to people, and therefore the groups have been able to share information and collaborate, but the access to the connections and to the mapping data would have made that much more efficient and effective, I think, for everyone to learn what countries. And I'll give you an example from here in the US. I'm part of a group that was brought together to amplify messages about access, equity, and acceptance of the vaccines during the COVID, the early part of COVID. We still exist. It's called Catholic Cares. and it was trying to bring Catholic groups from the United States together. And even that was sort of a one-off. And so having the data of those organizations, I think, would be very useful in having one place where we could go to get it. And this collecting existing databases and sharing that seems like a great first step. So thank you for all that you've all presented so far as well.
Thank you very much, Bruce. And we have some other thing, this is for Amanda and Barbara. Do you have anything to give you a perspective on Moy's views?
Could you repeat that, Edwin?
No, I'm just asking whether, you must have heard what Moy has commented on that. Do you have anything to give your perspective on that?
Yeah, I actually did want to respond. I thought the first comment from Moy was so astute, and knowing our audiences is really key as we're collecting and analyzing and sharing data. And frankly, I think we need to get better at telling the stories. Those of us who have started to understand or have known for decades the value of geospatial data and how critical it can be for prioritizing decision-making and for making sure we're not duplicating efforts, being able to tell those stories about why it mattered at the community level, why it mattered to the lives of individual people, why it mattered to the donor relationship, being able to tell that story to the appropriate audiences and getting very familiar with the storytelling side, I think is really critical and incumbent upon all of us as we're embarking in this space. And, what I love about this call is that we've got so many different communities represented. So when I talked about the policies earlier, we've got a local capacity strengthening policy and a geospatial strategy and a faith-based engagement policy, but really this group sits at the nexus of all of those different things. And so being able to communicate well and connect the dots between all of those different priorities is even helpful for USAID staff. And so remembering that perspective when you're going into conversations with donors and being comfortable being an educator back to even the agencies like USAID, I think makes a tremendous difference in helping us to understand the vital role and the assets that you all bring to the table.
Oh, thank you, Amanda. Barbara, do you have any quick comments on that?
Yeah, I would just echo everything. I just echoed everything that Amanda was saying. I think understanding the audience is absolutely vital. Telling the story is vital. One thing Amanda said earlier too was turning data into decisions, and I think Amanda said it so well too earlier. Collecting data for data's sake, I've done that before. It's almost the easiest part, but figuring out how to analyze it, how to make it make sense, how to make it relevant, and then how to share it appropriately. I know it's an area that we've struggled in. It's really important, and it's really important that we've learned and fumbled our way through it because it's absolutely vital. And we've made, if there's a mistake to be made, we've probably made it on collecting the wrong data or collecting data too soon without thinking through the total outcome of what we want. And so, I feel like I could write a book on what not to do sometimes, but it is really important to think of your audience and what you're trying to share, and then be able to convey that well. And I think one thing that I was just thinking as you were talking, Moy, about a role that the mapping consortium could have. I'm not saying that we have this role yet, but being able to help other organizations interpret and use the data for their work and to help scale and share their work may be something that the consortium can consider helping with going forward in a direct way, not, you know what I mean? So just something I thought of.
Yeah. Right, Barbara. Thank you so much, Barbara. That's well said, actually. And there are some questions, but actually we are running out of time. Our sincere apologies for not taking much question. And I just want to close, give the opportunity for the speakers. Anyone of you do want to make a closing comment on anything, whatever we have discussed so far?
Just thank you so much for having us today. Thank you so much for having us. We love to participate in calls like this.
Thank you.
Thanks.
Okay, thank you so much, actually. Oh, wow, this has been really a fascinating discussion, and we had wonderful discussion, all useful. And on behalf of Christian Council for Christian CCIH, and I would like to thank Amanda Barbara and Doc for their insightful presentations. And if you'd like to really engage in more of these kind of discussion, please consider joining the data and mapping working group. And I request you all to reach out to Bob, and his mail ID is given in chat box. And thank you once again for all the speakers and audience for their wonderful participation. And have a great day, and see you very soon. Thank you so much for joining us.
Thanks, everybody. Really appreciate the time.
Yeah, thank you so much.